Welcome to this webinar on Can I Ask You a Quick Question? Ad hoc supervision and informal teaching. My name's Simon Morgan. I'm a GP here in Newcastle and a medical educator working with GPSA. An acknowledgement of country, as we always like to do. GPSA would like to acknowledge the traditional owners of the lands on which this meeting is taking place and pay respects to their elders past, present, emerging and their families. And it's a great pleasure to introduce our two speakers tonight, both medical educators from GPEX. Firstly, Dr. Penny Neade, who's a GP and practice partner at Pioneer Medical Centre in Tea Tree Gully, South Australia. As I said, Penny's a senior medical educator at GPEX with an interest in supervisor education. She's undertaking a master's in clinical education through Flinders University and is passionate about quality general practice and its vital role in our health system. She aims to support GP trainees with a sustainable and rewarding career in medicine while delivering excellent patient-centred care. And accompanying Penny is Helen Mullner, who's worked in the same general practice since 2010, so 11 years now, in the Centre of Adelaide, where she worked as a registrar. So a long time in the same practice. That's fantastic. Simultaneously worked in medical education, initially working with interns and RMOs while still a registrar herself. Since achieving fellowship, she's been training registrars. She has a passion for training and upskilling supervisors, understanding that not all doctors intuitively have the skills to supervise registrars and that teaching the teacher is both necessary and important as well, hence her passion for medical education. She's worked in the role of primary and secondary supervisor. Helen loves the breadth of general practice, the expectation of the unknown walking in the door, and the highs and lows of healthcare across the ages, including obstetric shared care, peds, musculoskeletal medicine, and mental health.
Well, thank you so much, Simon, and thanks for the very warm introduction and something we've got to live up to now, so We'll do our best. So we'll start with our learning objectives.
By the end of this webinar, we would aim to be thinking about some of the principles of teaching and learning and how they might apply in corridor or ad hoc teaching. We want to improve teaching by recognising some of those opportunities, and we want to build some confidence and skills. I just thought I'd come back to the name corridor teaching. It's something that we've discussed a little bit. Penny, what are your thoughts on corridor teaching?
Yeah, so we decided probably we shouldn't be doing a lot of this teaching in the actual corridor. And there are different methods, obviously, for when your registrar calls for help. And we're going to get into that a little bit later on as well. So Is it in the room with the patient? Is it on the phone? How is it done? And less often in the corridor, sometimes in the tea room.
Yes.
And so we'll just move on now, and Helen's going to take us through the learning cycle.
So this is really just a reminder to think about the principles of learning and how learning leads to more learning. So if we think about any of our learning that we all undertake, it often begins with an idea that we need to learn something. So we formulate a learning objective, if we want to call it that. And then we decide how we're going to learn it. So that's where we plan our learning. That's where we say, right, I'm going to attend this webinar. I'm going to undertake this course. I need to upskill in this particular area. Then we actually do the learning. And we do the learning usually through some kind of experience. And then at the end of that, we evaluate, get some feedback, undertake some kind of assessment to see what it is that we have actually learned. Have we learned what we thought we were going to learn? Or have we now got some new learning objectives that are going to lead on to more learning? And with our registrars, whether they are new registrars entering our practice, whether they've been there for a long time, whether we ourselves as supervisors have been supervising for 10 years or forever, there will be that sense that there are always things that we can learn. And we all know that that's what we do in general practice. We've never come to the end of the road and have to stop learning.
It's time to stop now. No, that will never happen in general practice, absolutely. And this cycle just keeps going and going. So we thought we'd start by talking about some of our good learning experiences. I'll go first. So when I was a registrar in Crystal Brook, which is a small country town about 2 hours north of Adelaide, I used to have a supervisor there, and every time I would go and ask him a question, he'd say, well, Penny, what do you think? And initially I thought that was quite frustrating, but later on I realised that I needed to come armed with some things to think and some thoughts for myself. And actually I think it made my presentations of the patient case way better. And looking back, now that I know more about clinical reasoning, I think it was absolutely the best thing you could have done for me as a junior registrar there, to get me to actually have to commit to things, to put myself on the line, which was, uncomfortable at the time, but actually really helped my clinical reasoning process. So I really like that.
Yeah. And I think when we think about good learning experiences, we need to kind of unpack what it is about the good learning that has made it good. Is it the teacher? Is it the method that they're using to teach us? Or is it the content that we're learning?
Yeah, absolutely. And another good learning experience I always think of is this, and Helen knows who this is because Adelaide's pretty small, but it was a teacher that we had when we were doing molecular and cell biology at university, and she was just the most enthusiastic person. Like, we were learning about the lac operon, and anyone who's learned about that is pretty dull, right? But she could make that interesting just by her genuine enthusiasm. And she's still memorable to this day, that long after, because she just had a love and a passion for what she was doing. So,
and now, not surprising perhaps, we're going to counteract some of our good learning experiences with the not so good, or, well, let's just say it as it is, the bad learning. And really to think about, again, what it is about that bad learning that was bad. So one of my examples in this space is when I was learning to drive. I had a older male driving instructor, and I was learning to drive a manual, and his hand would often wander from the gear stick towards my knee. It was really incredibly uncomfortable, highly inappropriate. Thankfully, I still managed to learn to drive and still are able to drive in a manual, and am now teaching my daughter to drive in a manual. But it was a bad experience because it made me feel awkward and uncomfortable.
Yeah. And interesting, my bad learning experience is also driving, and I still don't really like it very much. So maybe we need to do some teaching for some driving instructors out there. The point of this exercise is just to get you to think, as Helen said, about what it was that made it bad. So just have a bit of a time to reflect on that in your head, and you might be thinking of some experiences now, and just think about how you're going to try and avoid those sorts of situations within your teaching and learning environment, within your practices.
Yeah. I think that really leads next on to thinking about our registrars as adult learners, and we've touched on the learning cycle, and now we want to think about what it is that makes adults learn and it stimulates a really good, safe learning environment. And one of the first things is that they're personally motivated. If we think about our registrars, they're in a GP training program. They want to learn to be a GP. They need to learn to be autonomous, to be self-directed learners, so that when they're finished in the training program, they've got the skills to keep learning and to keep being challenged and to keep that little list of things that they can go home and learn once they've got their fellowship.
And if you think specifically about ad hoc teaching, there's nothing more personally motivating than having a patient in front of you with a problem that you need to try and solve.
Yeah.
That is incredibly motivating.
And it is also incredibly relevant. When they've got that patient sitting in front of them, they have to have an answer. They need a solution right here and right now. So they are motivated, the problem is relevant, and they're going to learn something from that situation.
We're having a bit of trouble teaching people about travel health at the moment because the relevance isn't quite there. But we always say you retain something so much better when you've actually seen it in clinical practice, and it is. It's just that relevance and that need to learn that on the job stuff. Yeah.
I guess one of the other things with adult learners is thinking about pitching that learning at the appropriate level. And, you know, when we're talking about GP registrars, they're only registrars for a fairly short space of time, and there's not always seem to be a lot of difference between a registrar coming in at a GPT-1 level and a registrar who's just about to receive their fellowship. But there still is a difference. So we need to think how we can pitch that learning and that teaching opportunity at the right stage and the right place for that registrar.
This one I think is really important when we're talking about ad hoc teaching, is the need for an adult learner to be respected. So especially with a registrar who is trying to prove their way in the general practice, they're trying to, show their patients that they're confident and competent. And so the way you go about the teaching is really important to ensure that that registrar remains respected throughout that interaction. We're
going to come back to this right at the end as well.
Yeah, absolutely.
And I guess we've probably already covered this one. There's active involvement of the learner, the registrar, in that learning opportunity. When they're calling for you, they need your help, they're practically involved because the patient is sitting there and they've got to figure out what to do with them.
Adult learners also love some clear goals. this can be a bit hard in general practice because obviously it's so broad, but when we talk about ad hoc teaching, the goals are pretty well set. You know, we want to get the information that we need to help our patient with the problem that we're presented with at this point in time.
Yeah. And registrars, as adult learners, need some regular feedback. They need you to be touching base with them, even if they're a senior registrar, touching base to see how they're going, where they're at, where their gaps are, what the learning needs are for them at this particular point in time. And having that feedback and that assessment and that evaluation is a good experience for them, as well as the opportunity for reflecting on that.
Yeah, absolutely. And the time for reflection really fits in really well with that learning cycle you were talking about before. So being able to bring it all back as well. And often you may only have a small amount of time to do your ad hoc teaching, but you can come back to it later on when you've got a formal teaching session. Hey, remember when we saw you with Mrs. So-and-so? How did you go with that? What did you learn? And just completing that cycle can be a really helpful thing to do. So we're going to move on, and I always preface this with all models are wrong, but some models are helpful. Okay, so taking that into consideration, there'll always be obviously things that are wrong with all different models, but just take bits from them that will help you with your learning and teaching. Yeah.
So learning styles are really just recognising that we learn in different ways. I probably learn in a different way to Penny, and the registrars in our practice may well learn in a different way as well. As a supervisor teaching a registrar, whether it's ad hoc teaching or formal teaching, if I'm teaching them in a way that they don't really appreciate and that's not their best for their learning, there might be a mismatch, and that could be problematic. So it's worth, particularly at the start of a rotation when a registrar first joins your practice, just to have a discussion with them and see if they're familiar with learning styles. You can look them up online, and we're just going to take you through a couple just to get you thinking about it if you haven't come across it before. So the first one is the Honey and Mumford model. People may have heard these terms bantered around. They were two psychologists and educational sort of researchers in the mid-1980s, and they had 4 different types of learners. Activists learn by doing. They're practical, hands-on people. They need to get in there, learn through trial and error. Reflectors really like to observe and think about it. They don't always say a lot. So that might be the quiet person who you're not quite sure if they're actually on the same page as you. The theorists really want to unpack what is going on. They collect all the information, all the data, think about it, and they need to be convinced that something is the right path to be taking before they give it a go. And the pragmatists are perhaps a little bit like the activists. They're ready to give it a go. They're practical, they're purposeful. They don't necessarily stop and think about it an awful lot. This is just one model, and it's one that perhaps can be helpful. People are not necessarily one style of learner or another. They may fall into a couple of different fields.
Absolutely. And this is a preference often. So often, obviously, in general practice, you need to sometimes be a doer, and you need to sometimes sit back and think. And most people can do all, but it's a preference of a style. And it's good to know what your registrar's style is more like. So I'm a bit of an activist, so I like to do, and I don't talk in final copy. I talk in I'm thinking as I'm talking. And I kind of like, if I'm talking to someone and I'm doing that, but they're a real reflector, they don't talk until what that comes out of their mouth is that's the N word, right? And so if I've got a small learning group, for example, or a registrar, it's good for me to know that so that I can tone myself down a bit.
And put the filter on.
And put the filter back on, yeah.
So another model, just to briefly mention, is the VAK model, the visual auditory kinesthetic. And I quite like this one because I'm a fairly visual person and reasonably simple. I'm the doctor who sits there and tries to draw really terrible diagrams of body parts and explain it to patients. Unfortunately, I'm not gifted in artistic skills. So there are many patients, I think, who can't quite get what I'm talking about. But that's my approach. And I have to pick up on the cues of the patient. And in the same way, I need to pick up on cues of registrars and think, actually, that approach isn't working with them. I need to speak more and draw less.
Absolutely. And then we've just got a table here which just goes through, the type of learner you might have, and that's on the column on the side. And across the top, you've got the type of teacher you may be. So you can see that certainly if you've got a dependent learner, they love an authoritarian expert. Not probably the type of teacher and learner environment we love to promote in general practice. We more like to go through to have, learners that are not so dependent, that are really self-motivated and self-directed. That's what we're aiming for, but they're not all there, especially not the GPT ones. So you need to work your way through this process as well. And this can be just a helpful table to have a look at and have a think about where you think you are and where you think your registrar's at, and if you have a certain preference for a style of teaching too, which is often the way you were taught, can often be the way you prefer to teach.
So we're not necessarily saying that one style of teacher or one style of learner is necessarily right or wrong, other than the fact that we'd like the learners to become more self-directed. Yeah. But certainly there are teachers who perhaps need to learn some more skills of being facilitators and delegators, and less of those skills of being the authoritarian expert.
Yeah, absolutely. So that leads us on to a very simple but somewhat complex question. So what is teaching and how would you define it? So I just wondered if anyone's happy to put into the chat how they define teaching. We've got our own definition, but we're just interested to know how you would define teaching if you had to do it. So we've got talking to someone about something. Good, yeah, really simple.
I really like that.
And that's a teaching opportunity, teaching and learning opportunity, absolutely. So, and we've got Malcolm saying transmission of knowledge or skills from person A to person B. Yeah, absolutely, another good definition of teaching. Doctor equals teacher, Simon, absolutely right. It's part of our job description. And the sharing of knowledge, skills and experience, so bringing that a bit broader as well. So passing on of my experience, great. So some excellent definitions and thoughts about how you see teaching there. So this is another definition.
Yeah, so this, again, there are multiple definitions. This particular angle is thinking about teaching as a planned learning activity and the learning about a change in behaviour that has been brought about by the teaching.
Yeah, so ultimately you'll know that your teaching has been successful if you see a change in behaviour of your registrar the next time they're encountered with a similar problem.
Yeah, and I think that's really where we get to with opportunistic teaching, that if we make the most of these little tiny nuggets of time throughout the day, that the registrar won't necessarily come back to you with the same question if you've been able to teach them something and they've learnt something from that encounter, which we'll come on to a bit later.
Absolutely, absolutely. So next thing is, okay, so what sort of teaching do you do within your supervisory and registrar relationship? So what are the sorts of teaching activities and what sort of things do you do or use as teachable moments?
Informal case reviews, and that would be the number one, I think, that most supervisors and most registrars will report on as ways that teaching occurs in their practice.
Yeah, absolutely, number one. Yeah. So then you, after your informal ones, you've got your structured formal case review. So actually doing a formal random case analysis with your registrar, sitting down, and we couldn't recommend this highly enough. So sitting down with your registrar and saying, show me patient 3 on Tuesday, and then doing a formal random case analysis of that. And it gives you opportunity to see the notes and to have a really good understanding of how your registrar is going.
Yeah. This is something that not a lot of registrars, a lot of supervisors will use, but when they are used, they can be really valuable. Audits of registrar case notes, audits of registrar results, the results that they've got coming in their inbox, gives you an awfully great insight into what it is they're thinking. Are they ordering every test under the sun because they've got no idea, or are they really targeting those tests to what's going on?
Yeah, and one of our supervisors online has said that they do review case notes and provide feedback and finds it very time consuming. Yeah. And certainly we're going to talk a little bit about time, probably I think a bit later on as well. And referral letters I find can be really helpful to audit as well. There we go. Next one.
I think most people are familiar with topic tutorials. Registrars will often say things like, I actually have no idea how to start a patient on an antihypertensive. can you give me some tips on that? And you have a sit-down tutorial session on that. Not an uncommon way to be teaching.
But if you're struggling, GPSA have some fantastic resources online. So they've got a lot of all these topics, these beautiful 2 pages, even have some clinical reasoning questions on the back. Excellent for if you're struggling for some topic tutorial content to help guide you. Yeah.
And we can't recommend highly enough direct observation and video observation. Both you watching a registrar and your registrar watching you consult is highly valuable.
Yeah, absolutely. And we've got a second plug in the chat for the GPSA teaching plans. So
thanks, Malcolm.
They are great. Yeah, agreed.
Obviously, practical procedures is something that we're all familiar with. Some of you do this more often than others, but registrars really like to get their hands in and give things a go.
And then the last one's online learning. And so sometimes, if you're struggling for stuff to go across, getting online together with your registrar, you can sort of role model how you would learn or how you would look stuff up or the resources that you use, or even do a DermNet quiz together or those sorts of things as a teaching and learning opportunity.
It's also a great chance as a GP and as a supervisor to go, oh, actually, I wouldn't mind upskilling in that. Let's do that online module together.
Yeah, and Simon's happily very kindly put into the chat for us the link to the supervisor teaching plan. So have a look at those if you haven't before. Registrars are starting to clue into the fact that they're there as well.
Yep.
And DermNet quizzes. Thanks, Simon.
Yep.
He's on it. All right, fantastic. All right, so now we're going to get to what we're here to talk about. So we're going to talk about opportunistic teaching. Recent data showed that Term 1 registrars ask their supervisor for help in about 11% of consultations. So that's quite interesting, isn't it? So you're going to get called for help quite often with a GPT-1 registrar.
So whilst we talk about opportunistic teaching or corridor teaching, it is not unexpected teaching.
Absolutely. Yeah.
Which makes a difference in how we manage it, which we will come to shortly.
Yeah, absolutely. So our registrar is coming into our practice, but they're a bit more senior.
Mm-hmm.
So in what percentage of consults do you think a GPT-4 registrar asked their supervisor for help? Because it was actually 1.2% in this study that they did, which was less than I would have thought for a GPT-4, but maybe ours just asked 4 questions. But it really drops off reasonably significantly, doesn't it, as they progress through their training? And that's exactly what you would want and what you would expect. So what you tend to find is that the registrars in GPT-1 will tend to obviously call their supervisor for help probably as the first thing they will do. Yep. And as they get to GPT-4, they're going to look at other sources of help. So they might be looking up the resources that they now know everything about, and they know exactly where to find everything online when they need it during a consult. They might be more confident to do that during a consult. So they're going to be coming to you for help a bit less. So this is important to consider when you're trying to set up how you want to do your teaching of your registrars within your practice. So the next thing is, well, what are the things they're going to call you for help for? So that study that we showed said the most common things, and this is probably not a surprise to any of you, are dermatology and musculoskeletal. Mm-hmm. But how do the registrars know when to call for help? Well, luckily, someone has helped us out with this as well. So there is, again, it's available on the GPSA website, and it's the registrar call for help list. It's a really helpful tool that you can chat through with your registrar when they start out in your practice about the things that they should call you for help for. I find this is very empowering for registrars to be given a list and saying, look, please call me for these things.
I expect you to call me when you have a neonatal patient.
Yes.
I expect you to call me when you have an acute abdomen. Mm-hmm. It gives them that confidence to know that you're expecting that call, and that they don't have to fumble their way through it by themselves on their own.
Yeah, absolutely. And another really helpful bit in this document is at the front, it makes you actually really assess, are you genuinely approachable? Are you? And how readily accessible are you? Yeah. And have you done an assessment of how likely you think your registrar is to call for help when they need you? Are there any cultural barriers? Are there any psychological barriers for them calling you for help? And, are you present?
Many are using the landline phone. We're getting quite a number using the knock on the door. But it's also, perfectly reasonable, and given your particular clinic and the setup and your location, that they might use an internal messaging system or your mobile phone. So there's no right or wrong with you.
So there's no right or wrong, but your registrar needs to know. And they need to have explicit instructions on how to contact you and how you prefer to be contacted. Yeah. And if you're if there's somebody else supervising the registrar, then they need to tell the registrar how they like to be contacted as well. There's such a mix. So how's a registrar to know if they're not told?
Yes.
So, yeah.
So I think one of the biggest questions that supervisors come to us with when we run new supervisor workshops here at GPEX is that they know there are some big barriers to managing corridor teaching or the ad hoc teaching with their registrars. What do you think some of those barriers are?
Yeah, so here we want you to put some into the chat. And we're going to try to help with them.
Or maybe the biggest one.
Yeah. So what are some of the barriers to corridor teaching? Time, if I'm consulting, yes. Now, we didn't predict that one coming through, did we, Helen? Well, okay, we did. So keep thinking about some barriers, put them in there, and we'll try and come back to them. If they can see I'm busy or behind, that makes you less approachable, doesn't it? Like, registrars pick up on that too. I don't know the answer. Yes.
But that's okay, Simon. You don't have to know the answer. You just have to know where to go to get the solution.
Absolutely. And ask, don't tell. It's always a good philosophy if you don't know the answer. Timing and confidentiality. I'm really glad you brought up the confidentiality issue because I think that's a big one as well. So we're going to talk about some strategies before we move on to our model for opportunistic teaching. So strategies. So Helen, you have registrars in your practice.
Yes.
How do you set it up so that you can overcome some of these time barriers?
Yeah, so generally for our registrars, we have a primary supervisor, and the primary supervisor may not be there full time. I don't think any of our doctors in our clinic are there 10 sessions a week. And so generally when the supervisor is there, then they will be that go-to person for that corridor teaching. But the times they're not, hi Malcolm, the times they're not there, the registrar has a designated corridor person, and that person has nominated themselves. They know that they're the teaching person for that Wednesday morning clinic, and the registrar knows how to contact that person and which room they're in. We tend to move rooms a lot, so the registrar needs to have a cheat sheet that has Wednesday morning I contact Dr. Helen and she's in room 6, and Wednesday afternoon Malcolm's not there, so I contact somebody else. That's how it works in our practice. And Penny, yours is a bit different.
Ours is a bit different. So we have 2 registrars that have just gone across to GPT-2 now. So we had 2 starting GPT-1, and we quickly recognised that having a single go-to supervisor was going to make that supervisor too busy to be able to do effective consulting, especially in the early days. So remembering the stats of 11% of consults was for 3 months in. Now, 3 months, you've already done your steep learning curve, I think, in general practice. So even more so, you need to be prepared for that registrar to be calling you for up to 1 in 2 consults, or in the first few days, maybe every single one, you might want to do that. So if you don't change your diary, you're going to get into trouble. So you need to put some catch-ups in your diary. And as Helen says, you front load it. So you know that you're going to need more catch-ups and more time when they're starting out and it's early, and you'll be able to back that off later on. But your supervisor that's responsible for the registrar during that time, especially for a GPT-1, needs to have that time put aside to be able to do that. Else it's just stressful for everyone.
Registrars also need to know if there are doctors in the clinic who don't want to be contacted. And they also need to know how to contact other doctors if you're not available.
Absolutely.
A couple of the comments in the chat, if you're busy, if you're with a distressed patient, if you're in the middle of a procedure, you might not be available for that registrar. So then they might do the wander up and down the corridor looking for an open door. Is there an alternative as a backup? Being a solo practitioner, there's unfortunately not a lot of sessions as backup.
Yeah, so that can be really busy. But where you can, just allowing yourself to have that extra bit of time will take the pressure off both yourself and off the registrar as well. Some of the other barriers people came up with there is registrar's too shy, doesn't want to show their lack of knowledge in front of the patient. One of the best things you can do here is role model. So sometimes pick up the phone and ask your registrar for advice about somebody you're seeing. If your registrar's just come off of 6 months in orthopaedics training, call them when you have something that's relevant to ask them about, and just role model that you too ask for help. And I think that can be a really powerful way to overcome some of that shyness potentially. And then not wanting to look silly or making sure they know everything. Again, I think this can come down to the conversations you have when your registrar starts in your practice and setting that culture of learning within the practice And being really supportive to that as well, I think, can be really helpful.
So now we're going to talk a little bit about a particular model. Again, this is but one model. And it's really thinking about those opportunistic teaching times that you have with a registrar, so that you're not just providing that answer to get them moving and you both be able to get on with your consults, but to think about how you can make it a valuable teaching opportunity. Now, this particular model is the 5 microskills method. Some people know it as the 1-minute preceptor model. And it's really thinking about how can I get a commitment from the registrar first, as Penny said, ask, don't tell, probe for some supporting evidence, reinforce things that they've done well, think about anything that they might have missed, and then think about a general principle that you might be able to teach them. I'm going to show you, for those who are perhaps a little bit more visual like me, a little bit more graphic representation of this. It's graphic because it's got some arrows and a little pretty picture in the middle.
Makes it so much easier to learn, the arrows.
But again, it's thinking about how we can progress that registrar through a potentially simple problem or a slightly more complex problem. And we know that you guys probably all love role plays, so we thought we might give you some demos.
Yeah, let's role play.
Okay.
So I am going to be the registrar.
Okay.
Calling you for help, Helen.
All right.
Okay, you ready?
Yep.
All right. Hi, Helen. How are you going?
Yeah, good. What's up, Penny?
Good. I just wondered, a quick question. I've got a 32-year-old lady here, and she has size G breasts that are giving her a lot of neck and back pain.
Right.
She's looked into it. She's done a fair bit of research, and she really wants to have a breast reduction. I'm just after who you'd refer to for that breast reduction.
Right. So what do you think is going on here, Penny?
I think she has really large breasts and needs a reduction.
Okay.
Yeah.
And what makes you think this, Penny?
She told me.
I don't think this model's going to work.
Okay, so it didn't work for that situation.
Yep.
Okay,
Right.
And so obviously a little bit tongue-in-cheek, but just models are tools for you to use when they're helpful and when they're meaningful. This is not a rule book. We do not expect you to do this every single time your registrar asks for help. That would not work.
Let's try another one.
Okay.
All right.
I'll be the doctor now.
Okay, I'll be the registrar.
Oh, we're both doctors, but I'll be the more senior doctor.
Penny?
Yes.
Penny, could I please have your help? I'm in the treatment room. I've just given a flu shot to a 60-something-year-old lady, and she's kind of struggling to breathe, and she sort of looks a bit blue, and I really just like you to come and see her, please.
What do you think is going on?
Yeah. She's not breathing, and I need some help. I'm worried about, I don't know, anaphylaxis or something.
Anaphylaxis.
Could you please come down?
What evidence is there that she may have anaphylaxis?
Yeah, Penny.
Okay, it's not working again. All right. So again, a bit silly, but in an emergency, this is not going to help. Okay. So no 1-minute precept in emergency. Run.
Okay. So let's
run
think
and help.
1 minute.
Okay.
With a real problem. And this is going to be the bulk of those questions that registrars ask you on an ad hoc basis while they're in the middle of seeing a patient, where you can actually make it into a valuable learning experience.
Okay, we'll do it properly this time, we promise.
Okay. All right.
And I will be the registrar.
Yep.
Okay. Oh, hi, Helen. I just wanted to ask you a question about a patient. I've got a 4-year-old little girl here, and she's come in with a rash on her leg. It seems to just be in sort of one sort of area, a little bit like a cluster.
Yep.
And I'm not sure what it is, and I wondered if you could come in and have a look.
Yeah, sure. So what do you think might be going on here, Penny?
Well, it's a really good question. So I'm not exactly sure. I've never seen a rash like this before. Initially, I was thinking, young girl, lots of spots, could it be chicken pox? But I don't really think it looks like chicken pox, and doesn't sort of started centrally and gone peripherally. And also, I don't actually think they're vesicles. I can't see any fluid in the lesions. Some of them look a bit irritated.
Yeah.
And so then I was thinking, is it warts? And I thought, well, it could possibly be warts.
Yeah.
And then I was thinking, hand, foot, and mouth, but no, it's not in the hands or the feet or the mouth. So just, I have heard of this thing called molluscum before, but I've never seen it before. So I thought maybe that could be what's going on. But honestly, I'm not really sure.
Okay. So it sounds like you've really thought about a number of possibilities. Have you thought about looking up any of those references, like those DermNet reference that we talked about?
Yeah, so initially I was thinking, maybe school sores. So I looked up school sores, but it doesn't look like school sores. There's no crusting and all that sort of stuff. So I don't think it's that.
Yeah.
And then I was just trying to sort of felt, look, I don't really know.
Yeah. Sure. How about I come down and have a look?
That would be great.
And it's probably worth us scheduling for our teaching session on Friday to think about rashes in kids.
Oh, that would be really good because, dermatology.
Yeah.
It's a struggle.
Perfect.
Okay, thank you. Yeah.
All right. We know it's a little bit naff, but gives you a bit of an idea how you can make something into a bit more of a broad teaching opportunity. It also gives me a chance as a supervisor to gauge her clinical reasoning skills and see what things she's thinking about, and also then to plan some learning down the track.
So you've been able to, in that interaction, sort of get a bit more information and potentially diagnose what you think is going on with this rash, but also diagnose your clinical reasoning of your registrar.
Yeah.
It's so easy to just go in there and say, that's molluscum, which is what it was. But so much more powerful to do it in that method. Yeah.
Now, we do have another model that we're going to really quickly whiz through.
Now, very exciting. We're just having a few troubles with our slides. But this model has just been published this week in the latest version of the AJGP in an article by Simon Morgan. So those of you who are astute will notice that it is based on how you interpret an ECG with a PQRST. And it's a model that you can use for both ad hoc teaching but also your case discussions. So you can use it for both. And the difference between this one and the 1 minute preceptor is that it explicitly articulates that you're going to solve the patient's problem, whereas the other one doesn't necessarily do that. So P stands for the problem representation. So you want your registrar to present this to you in a certain format. And ideally it's sort of the patient demographics and risk factors first, then the temporal pattern of the illness, and then the clinical syndrome. That's ideal. Then you need to know exactly what is the registrar asking for. You may need to do a few more questions around this to find out exactly the question they're trying to ask. And it can fall under 3 categories. So they're asking for rescue. That was our patient. We can probably stop our PQRST there and just run into the room. They're asking for assistance, and sometimes they're just asking for reassurance. Is this the right management plan? And certainly as registrars progress through training, more times than not, that 1.4 times that they're calling, they've already got a reasonable plan, and they just need to run it past you. So find out actually what they're asking, and then reasoning. So now we can really assess our registrar's clinical reasoning. How well do they reason? And you may need to ask a few more questions around this, but you can do that explicitly. And then S is for solution. So we want to maximise the clinical care of this patient, and we need to address any gaps in the learning of the registrar. Again, you don't just have to give them the solution. You can ask before tell still. You can still use that method. And then the last one, the T, is what can be taught. So we're going to complete that learning cycle now. So a really helpful little tool, and hot off the press, signed copies in the foyer by Simon. So yeah, very excited that there's a new model out there that we can use across the board, and that explicitly addresses what the registrar is doing, because the primary role of this ad hoc teaching is to deliver quality patient care. And so this model also does that as well. One thing I could recommend is printing off the 5 micro skills or the PQRST model, whichever one you prefer to use, and just putting it next to your computer or next to your phone where your registrar normally calls you for help. It's just a bit of a reminder. Doesn't take up much space, and it just means that when they call you for help next time, you might ask, not tell, as a first step.
And I think that's my biggest piece of advice. It's really easy, particularly when they come to you with a problem that you know the answer to, or that you're already running late and you want to just get them moving to get back to your busy consulting session, that you just want to tell them the answer. Pause, take a deep breath, and ask them what they think is going on.
Yeah, fantastic. Thanks.
I think ask before tell is probably the primary thing, but it's one of the really important things is just to say, no, just give me the case summary. Just wrap it up into 2 or 3 or 5 sentences, and that is the way to work with it, but also, as you said, to assess reasoning. How well is this registrar identifying the bits that make a difference?
Absolutely. And the thing is, to be able to give a good, concise case summary, you need to be able to pick out the key features. You need to be able to choose the bits of the case that are the most important to tell your supervisor. And if you find your registrar telling you all this extraneous stuff when they're meant to be giving you a quick summary, there's a red flag there.
And you need to train them. You need to train them early, as Penny said when she was in one of her placements as a registrar, that she knew to expect that her supervisor would say to her, what do you think is going on? Yeah. And I think if you can train your registrar to be thinking that, then they will present it succinctly, they will pick out those key features, and they will then ask you the question that they want to ask you.
Yeah, absolutely. And the better the registrar does their case presentation, the more autonomy and the more power they feel over that consult, and the more likely it is that you're going to be playing a helpful role rather than a taking over role as well, and having to ask all that history again. Yeah.
So we're almost out of time. I can't believe it's gone so quickly. Just to get to the last little session that we want to touch on, it's really to think about the times that you physically go into the room with your registrar and your patient and what that three-way interaction might look like. It's going to look different in different contexts, and it's not necessarily that one way is right and another way is wrong. There are times, Penny, when the patient might actually be the outsider.
Yeah, absolutely. So you come into the room as the supervisor, and the registrar gives you this fantastic presentation, and you go through your 1 minute preceptor, and you're chatting, and the patient's sitting there going, what about me? So just recognising the patient. I tend to do that by coming in and saying, hi, how are you going? And then turning to the registrar and saying, okay, so that I've acknowledged the patient, and then I'm letting the registrar take the lead as much as possible.
And I think also for registrars to be empowered to know that when they are calling you, they are calling a senior doctor for for a second opinion or some more information. And so therefore the patient is a privy to that educational experience. Some patients are not going to like it as much as others, but many patients actually quite like it.
Yeah, and some registrars need to practice their script of how they're going to say to the patient, I'm just going to call my supervisor for help. Yeah. I'm a doctor. I'm just in the GP training program, or whatever it is, however they like to say it. Sometimes it's good, even in part of your orientation, to go through their script with them. Yeah. So what are you going to say to the patient when you call for help?
So another possible scenario in this three-way interaction is when the registrar really becomes the outsider. And the times that I've certainly seen this when I've come in as a medical educator doing an observation visit is often when the patient has been a patient of the practice for forever, and they've known the supervisor forever, and they come in, hello, Mrs. Brown, how are you doing? And how's your granddaughter? And it's so lovely to see you. And how are those legs? And you actually forget that the registrar called you with a specific question, and they were going to present this to you and have a little corridor teaching session.
And sometimes the patient is the one that triggers that. So they're like, thank goodness you've come in. I'm going to tell you my whole story now. Yeah. So it's good to have some methods for sort of saying, thanks for that. I'm just going to hear what Dr. So-and-so has done so far,
So another possible scenario is when you come in as the supervisor and you feel like you're the fly on the wall. The registrar kind of just carries on with the patient. And often this occurs because the registrar is really just needing that reassurance. They're needing you to kind of observe and to okay what they're doing. And you're almost feeling a bit superfluous. But often it's a great opportunity to then congratulate them and say, well, you've actually done a good job. You're all on track. I don't think I'm needed here.
Yeah. Absolutely. We had a quick story. I know I've only got 2 minutes left. But we had a registrar in training once who was really struggling and calling a supervisor for help all the time. And the solution that we came up with the practice was to give the supervisor a bit of extra funding to have a bit of time at the end of the day to catch up with the registrar, which meant that the registrar could then formulate their own management plans, institute them, but they could still check in with the supervisor later on. So if you're coming across that in your training, that's a good solution. It worked quite well.
And then, of course, with this three-way scenario, there might be times when it really is a genuine three-way interaction between the supervisor, the registrar and the patient. Again, none right or wrong, but just be mindful of this. And it comes back to one of those principles of adult learning that we learn best when we're well respected. We don't want registrars to be undermined, and we don't want patients to feel like nobody knows what's going on.
No, thank you very much. Well, we've had some discussion and we've had the opportunity to interact. And what I intended to do in developing this webinar series was very much to hear the views of a range of educators from around the country, people who've worked in GP supervisor professional development for a while. And it's just so refreshing to hear. I mean, this is a model I know very well, but to hear it presented in a different way, a different pitch. That sort of notion at the end of where the supervisor, the registrar and the patient sits in the dynamics is not something I've really heard articulated before. So it's just lovely to hear, old material presented in a novel way and in a fresh way. And so thank you so much, Penny and Helen. And you guys, I'm just thinking how wonderful it would be if supervisors could do exactly as you've done tonight, and that's, play off each other, the way you present and the way you teach. And it is so nice to be able to teach as a pair or a group. We don't have that opportunity in the supervisor world very often, but if there's scope, you've just seen it incredibly well role modelled tonight. And that's just an acknowledgement, which we always are very, very keen to do, and to make an acknowledgement to the Australian government under the AGPT to support this webinar and those like it, and all the other educational and other resources that the organisation produces for you. We're very grateful for their ongoing support. I'd like to thank you guys for coming along and contributing, and lastly to thank Penny and Helen for joining us tonight from what looks like a pretty liberated South Australia. We don't see anyone sitting that close together without face masks on at the moment in New South Wales. So thank you very much for what was a wonderful session.